Welcome, everybody, to this edition of Lipid Insights. Today, we're going to talk about a subject that many of us are just experiencing or may not have experienced, but those of us who have found this to be a really important diagnosis, which is statin-induced autoimmune myopathy. And I'm very happy to have Lisa Christopher-Stine, who's not only an MD, but a Master of Public Health. She's a professor of medicine and neurology and director of the Johns Hopkins Myositis Center. So thank you very much for joining us on Lipid Insights.
Thank you so much, Dr. Brown. Really a pleasure to be here.
So I remember thinking as a young lipidologist that this is one of those things that only happens once in a lifetime, if you're lucky, that persistent myositis from being on a statin is so rare. And then in my own experience, just over the past several years, I've seen 3 or 4 cases. So can you give us an idea of what the incidence is and maybe a little bit about what is autoimmune statin-induced myositis?
Yep. So I, like you, had the same sort of idea, but it was exactly that we saw. So we started a center at Johns Hopkins where we concentrate on muscle disease. So this myositis center, we assumed we would see mostly dermatomyositis, then what was termed polymyositis. And it turns out, while of course we did see those types of myositis, we saw exactly what you described. So patients would come in, they would have been exposed to a statin, and we can talk about this, but often in the not immediate past, but they've been on a statin for a while. And they themselves would come in and say, I think my weakness, my muscle symptoms are from the statin. And obviously, logically, we would say, well, it can't be from the statin because you didn't just start it. And they would stop the statin and they would continue to get worse. And again, this was a paradigm that we weren't familiar with, but patient after patient actually thought this. And so it stuck with me. At the same time, if you do a muscle biopsy, we were seeing not only necrosis, which, as you know, you would see with a statin toxic myopathy, the self-limited form, where we'll see necrosis, but we saw MHC class 1 upregulation, and there was complement deposition. So this looked like, from my neurology colleagues actually educating me as a rheumatologist, we have a multidisciplinary center, and they would say this is an immune-mediated necrotizing myopathy. And that term wasn't even something that we understood. Like, that was coming from the neurology literature from the early 2000s. 2003 was the first time that they ever even published criteria for this. So as a rheumatologist, clinically, I was thinking, oh, this is quote unquote polymyositis. And my colleagues taught me that. You'd asked, how common is it? I think this is debated. I always say sort of, if all you have is a hammer, everything looks like a nail. So certainly we see it. The published literature says somewhere around 1 in 100,000. Some people have estimated it as low as 1 in a million, and I think that's wrong. So I would say likely more than 1 in 100,000, but that's about the published rates. And I always challenge people that once you hear this clinical phenotype, you'll find one. So to me, that says it's probably more common, and maybe that's why you're seeing more than you did.
Yes, I'm going to just give an illustrative case and get your thoughts on it.
Okay.
So I had 60-year-old South Asian male referred to me. He had bypass surgery. He had type 2 diabetes. And after his bypass surgery, he sort of had failure to thrive. And he continued to get weaker and weaker and weaker until he was evaluated and found to have very high CPKs. And then he was sent to my clinic, and he was in a wheelchair when I saw him. And as I heard the story, I realized he was discharged from a surgery on high-dose atorvastatin, 80 milligrams, which is guideline-based. And he had just persistently gotten weaker, had soreness in his muscles as well as the weakness. So that's when we suspected statin-induced autoimmune myopathy. And he had already been taken off his statin because of the high CPKs and had not gotten better. So we ordered HMG-CoA reductase antibodies, HMG-CR antibodies, and referred him to rheumatology. So, I'll tell the rest of the story when I hear your thoughts about that phenotype, because I think maybe our audience hasn't got a picture in their mind of what this looks like. So,
I mean, that couldn't be a more classic phenotype. You described so many of the patients that we saw. So either they were put on a statin for cardiovascular risk protection, or they had already had an event. This was secondary prevention or primary. So your patient is exactly that patient, having weakness, usually proximal weakness. And they even interestingly describe myalgia. When I went to medical school, they taught me that autoimmune muscle disease is a painless weakness. And I had that in my head forever. But the patients would come in and tell me that they had myalgias. And I would try to tell them that, no, they don't. It turns out they do. And that's true across a lot of the autoimmune myopathies. But this one in particular, up to 75% actually talk about pain. So your patient, lots of things come to my mind for him. Put on atorvastatin. So we have published a small study that shows, I hazard to say a risk factor, although I personally think likely, but certainly a strong association. If you look at all the statins, atorvastatin seems to be highly associated with this phenotype. So atorvastatin, number one, widely prescribed drug, but even if you control for that, we still believe there's a signal above that. So if you even take out the compounder.
As opposed to other statins, atorvastatin's more.
For sure. And even the more sort of, one might think more lipophilic statins or things that should be more myotoxic don't seem to have the same signal for HMG-CR associated statin myopathy than atorvastatin. The other thing that we also noticed is that type 2 diabetes seems to be also another independent association or risk factor. The combination of atorvastatin and type 2 diabetes, which is not uncommon, it's a 100% guideline driven, prescribing. Now at these intense doses is a setup for this. You might ask, and people have, and we've actually tried to hammer down on this. One of these days, I think we'll come to the conclusion it's probably a dose effect. However, we've seen people develop this even on 20 milligrams of atorvastatin. So it's not 100% dose specificity, but it does seem that when people either start high dose, like your patient, or start accelerating the dose, that's when it presents itself.
Okay, well, I'm going to talk to you a little more about what we did with that patient, but before I do, I had a fellow rotating with me in the lipid clinic at the time, and I told him I want you to review the literature on this, because we don't see it all that often, and I'm not sure it's clear what the best treatment is. And as we reviewed all the literature, we discovered that there are patients who get the same disorder without ever being exposed to a statin. So tell me a little bit about that, and is there any idea what the mechanism is, and what else might predispose them?
I'm so glad you bring it up, because we often call this statin-associated autoimmune myopathy or autoimmune necrotizing myopathy, which it is, but HMG-CR antibodies do present themselves in statin-naive patients. This was such a conundrum, so I'll take you back a bit and tell you how we got here, what we understand about statin-naive patients, and why we know that's true. The way that we initially discovered the HMG-CR antibody was that we had a prospective cohort of patients. We would follow them longitudinally, and we were fortunate to be able to take a serum sample, correlate that with their clinical history, bank that sample, and then look for known and unknown autoantibodies, myositis-specific autoantibodies, by using HeLa cell lysates. When I say we, these are great colleagues of mine, Dr. Olivia Casciola-Rosen, Dr. Andy Mammon, who were all instrumental in the original discovery of this disease. We were starting to see that there was an antibody precipitating at 200 and 100 kilodaltons. So we called it the 200-100 antibody, and before we knew it was HMG-CR. We gathered those patients, and independently, those patients who had this antibody profile, my colleague Andy Mammon, who's a neurologist and neuromuscular specialist, independently read the biopsies and said, let me see what's in these biopsies. And the vast majority of these were exactly what we described, which is an autoimmune necrotizing myopathy. We noticed that there seemed to be the story that we started this whole discussion with, which is, I think it was the statin. The patient was saying this. So it turns out the patient that said, I think it was the statin, tended to be in that group. And there's 63% of those patients were statin exposed. So we felt like that antibody had something to do with cholesterol metabolism or cholesterol synthesis. And I'll, point to this slide for you to look at cholesterol synthesis and statins. So we recognize that there is a large cascade starting from acetyl-CoA all the way to cholesterol. And certainly I don't have to tell you that statins block the rate limiting step in the cholesterol cascade, which is, so HMGCR is that enzyme. We had postulated where this antibody could play a role, and quite frankly, it really is a serendipitous sort of crazy Cinderella science story that someone recognized that HMGCR weighed 97 kilodaltons. So that's how we first went backwards, did IVVT, showed that in fact that antibody was the HMGCR, was HMGCR. What we then said is, okay, well, what's the difference? Why do some people that seemingly are statin naive seem to get the disease? Started thinking about, could there be statin associates, whether statins in our water, are there mushrooms? And some of my colleagues even looked at this. And so high mushroom supplements that have a high amount of mushrooms in them, certain mushrooms, have actually natural statin chemical equivalents. People take red yeast rice, which is essentially, chemically equivalent to lovastatin. So we thought about that. We questioned people, and we could not find that most people were taking mushroom supplements or red yeast rice or anything else environmentally. So it left us with a third of the population that seemed to be statin naive. If you look across world cohorts, that number is different. In China, only 15% of patients seem to be statin exposed in their large studies. And so I assumed that maybe statins are given less often, that they're not prescribed. And it turns out that's probably not true. So there may be something about HLA typing or genetic background. In Australia, close to 90% were statin exposed. And we actually were not the first people to see this. This was described in Australia by Dr. Marilee Needham and colleagues. Up in Boston, Anthony Amato, who's a neurologist, was also seeing this. So, but to get back to your question, how many people are statin naive? It varies. The statin naive folks tend to be younger. And maybe just because they're not prescribed statins, they more often in our cohort, obviously this is different throughout the world. I practice in Baltimore, so we tend to see a more ethnically diverse population, and we have more Black patients probably in our cohort than some might at different geographic locations in the US and certainly worldwide. So our patients tended to be a bit younger, tended more often to be Black. And if you looked at their biopsy, they tended to have more lymphocytes. So they had more of a brisk inflammatory infiltrate, whereas those who took statins seemed to have more of a necrotizing phenotype in the absence of lymphocytes. So a classic autoimmune necrotizing myopathy. The others looked a little bit more like an overlap with traditional myopathy that's autoimmune, where you would see lymphocytes. So they're a little different.
So let me ask you about that. Thank you for that very eloquent and detailed description. Did you see any crossover? Like sometimes we see cross-reacting antibodies in lupus and other autoimmune diseases where we might get an antibody to a protein related to triglyceride metabolism or something else. So there wasn't any correlation with any other autoimmune disease in the statin naive patients?
No. So nothing that jumped out. Autoimmune thyroid disease is just common in general in our patients. They seem to have a background of this, but even that didn't seem to be more common than you would see in the general population of people with myopathies that we saw. There was no seeming association, either autoimmune, environmental, genetic. We really just could not find one.
Okay, so let's take a breath for a moment and just think about what our audience members might be thinking. So I always separate statin-induced muscle symptoms into the common ones that are not dangerous, which is myalgias primarily. And when you stop the drug for 7 to 14 days, they disappear. To muscle pain that's unrelated to the statin that the patients perceive as statin-induced, where you stop the drug and it never goes away, to more serious, dangerous situations like statin-induced myositis. And we tend to tell patients, stop your statin for 7 to 10 days, and if you don't feel better, it's probably not the statin, especially in those who don't have CPK elevation.
Right.
This is a whole different animal. It's hard to miss these patients, in my opinion. They are sick, and if you don't treat them early, they can have persistent muscle loss. Is that correct?
Yeah, it's mostly correct. So I'd say that's absolutely right. And it's not subtle. In general, the CKs that we saw in our initial description were the median was 10,000. It wasn't low. If you now look at a huge cohort of patients, obviously you'll get a wider spectrum. So some people have CKs that are on the little lower side. The vast majority that present to us, though, have CK over 1,000. The vast majority. So you're absolutely right. The one caveat, and then it's odd, is that some of these patients actually aren't super weak. They have myalgia first. And we postulate that how is it possible that your CK could be 5,000 and you're still walking around? As a matter of fact, you're probably not even so weak without, provocative measures to really bring that weakness out. Again, this is more theoretical, but I think in speaking to lipidologists, to nephrologists, why don't people develop rhabdomyolysis? Why aren't they weaker? It's probably because of likeliness is how slow the onset is, and there's probably compensation. And then there is this, as you know, regeneration of the muscle is probably outpacing degeneration in the beginning. So for some people, they come to us with more myalgias. We're shocked to find out their CK's 3 or 5,000, and they're not weak yet. We do think, to your point, that without treatment, almost all of those, if you leave them long enough, they're going to progress to become weak. And then you're correct that inflammation that's unbridled over time becomes atrophy or fatty replacement of the muscle, and then it's irreparable. I just will caution that there is a very, very tiny segment of this population that if you leave them alone, they will spontaneously remit, but that is by far the exception and not the rule. So you're absolutely right, recognizing them and treating them so your patient doesn't get wheeled in the wheelchair, which I've had happen, where the statin is actually continued because people didn't realize this and they're wheelchair bound. So absolutely.
So I think this discussion should be very helpful to our colleagues because a lot of what we see is so-called statin intolerance. And if you've got a patient that has persistent myalgia or progressive weakness, it's very important to think about autoimmune myopathy and work them up, starting with the CPK and then if you suspect it, the HMG-CR antibody. And is there anything else in terms of diagnosis? My understanding was the biopsy isn't real specific, but the HMG-CR antibody is. Tell us a little more about that.
Yeah, so I'm a rheumatologist. If you talk to a neurologist, they'll probably tell you everybody should have a muscle biopsy. And I've gone back and forth on this. I often say if you have the diagnostic testing, it's about 95% sensitive and specific. It's a very good test, and that's good in both directions,
for
right?
The antibody.
Yeah, so if HMG-CR antibodies are positive, you can, in the right clinical scenario, which is usually exactly as you described, you can be fairly confident that's the diagnosis. Many neurologists will say, you can never go back in time. You should get a muscle biopsy. What if there are complicating factors or they become difficult to treat? So there may be some things that we don't appreciate. I will say if patients push me and say, what more might you learn from that biopsy that you don't know from this clinical test? I can't say with certainty. And they said, well, can I be diagnosed? Because this is a diagnosis with this test alone. So I say, well, yes, in your situation, yes. So many patients would forego the biopsy if given the choice, obviously. So I think that's a little TBD on whether we should do biopsies more than we do. Most neurologists will biopsy. More and more rheumatologists are not biopsying. I think that's what's heading down this way. You had asked me a bit about also sort of the nuances and the differences between the two.
Between statin induced versus statin naive?
Yeah. Oh, no, I'm sorry. Let's make it clear. It's between statin associated autoimmune myopathy and the more toxic myopathy that you're much more used to seeing as in lipidology, endocrinology, lipidology, cardiology. More often to see the self-limited or toxic variety. And I often show a chart, which would be this slide. I often show a chart looking, you had asked me about the incidence earlier, the incidence of what we're speaking about today in the statin-associated autoimmune myopathy is rare. We say about 1 in 100,000, maybe as much as 3 in 100,000. You know this, that the common things are common, and depending what you call statin myopathy, 13% of statin users will say they have symptoms, and that's really actually probably low. If you look at other studies, up to 33% say that. So much more. Talking about 33% of people say maybe I have some muscle symptom, whereas the autoimmune version, 1 to 3 in 100,000. We touched on the fact that any statin, I think, can certainly cause the self-limited version, but atorvastatin seems overwhelmingly more likely to be associated with the statin associated autoimmune version. So we didn't talk a lot about the duration, but I think you had mentioned most people with self-limited statin symptoms tend to get them relatively early in statin treatment. It can be a few weeks, or I don't know, in your experience, maybe months.
Yeah. When we looked at it at the NLA, on average, about a month for onset, but it is pretty variable.
Right. So
I know a patient, I personally got it a year after I was on therapy.
Wow.
And I hear lots of patients who say that it's just very subtle, where they feel a little bit of fatigue and weakness, and then all of a sudden they get Charlie horses. That can build up over time. But I think on average,
more like a month, weeks to months. What we saw, which is so interesting, is that really fairly consistently, and this is true across studies across the world that's been replicated, the average duration seems to be like 36 months, 3 years of statin treatment. So you can imagine how perplexed we were and how we were all but certain that there's no way the statin played a role in this, because what would possibly come on 3 years later, but this does. Myalgias for sure in the self-limited version, and we touched on that earlier. Statin associated autoimmune myopathy hurts, and really like 75% of the time. So definitely sometimes, probably more than not. We see a lot of dysphagia, which is again not as uncommon in the autoimmune myopathies. I think, correct me if I'm wrong, pretty uncommon in the toxic version, the self-limited statin myopathy. I have not really appreciated swallowing difficulties in that, right? So,
I haven't ever seen that published. That's interesting.
Yes.
So let me take you to the next step then. So we've talked about diagnosis, about understanding the pathophysiology a little bit, the fact that you don't have to be exposed to a statin, and very interesting to me, new knowledge, that atorvastatin is associated with it more than other statins, which at least is an observation that's very interesting. So just to finish up with my case, he happened to be a diabetic, and he happened to have coronary disease. So stopping the statin was a dilemma. He had dyslipidemia off the statin. And traditionally, my rheumatology colleagues always seem to throw steroids and then methotrexate and then immunoglobulins maybe, and then Rituxan on these people. And I'm going to ask you to elaborate on the treatment. In his case, we couldn't give him steroids because he was diabetic, and we had to treat him with something to lower his lipids. So he ended up going on a PCSK9 antibody. But prior to that, we sent him to rheumatology, who initiated immunosuppressive therapy. And because he couldn't have steroids, he went through a course of methotrexate, which wasn't very impressive in terms of the response. Eventually, immunoglobulins, and I think eventually Rituxan is where he really got better. So with that introduction, when we refer these patients to rheumatology or neuromuscular, what is your approach to treatment for them?
Sure. I think the first comment you made is so true. For a while, we didn't have PCSK9 inhibitors, so we had no therapy. And what we noticed is that we were able to say, good news, you can stop your statin and we'll treat you and you're likely to respond. Bad news is people were restenosing and coming back with another MI or needed another stent. And it was disheartening because while I mentioned atorvastatin seems to be the most associated statin, you sort of prime the pump in some ways, right? So you can't seem to take any statin.
Yeah, but nobody would have the guts to do it. And I should tell you, we were a little bit dicey about giving monoclonal antibody to somebody who has an autoimmune myopathy. That's an ongoing question. Probably there's no issue there, but that's something that doctors are afraid of because does it stimulate the immune response? So is there any data?
As a matter of fact, we published it. So we looked at exactly clinically these patients that were placed on this for clinical reasons where they needed to have lipid lowering, and we said 100% contraindication to statins. So we had a small case series and studied this and found out that in our experience, and I would say that's true from that time on observationally, that PCSK9 inhibitors seem to be globally pretty helpful and are not associated with worsening the disease. In 2 patients that actually seem to help their disease, again, completely just maybe serendipity, I don't know. But it's an interesting thought.
And I'm assuming at that time that you published that, the antibodies were the only thing available. We didn't have siRNAs.
Correct.
Yeah.
And that data I don't know. So if you had asked me about bempedoic acid and all of the newer sort of amazing amounts of lipid lowering therapeutic classes, less data there, but I would suspect it's probably similar. But we were so grateful that PCSK9 inhibitors were available initially, because then we didn't see the cardiac events. They were largely prevented from happening again, where we were really struggling before that.
All right, so take us through the treatment. When you see one of these patients, they're off their statin, or if they're statin naive, they come in wheelchair bound or weak or painful, and what are the steps in the treatment?
There may be a difference in the treatment between statin naive and statin associated. I personally think so. I'll speak actually to the rarer version, which is the statin naive patients. They seem to be sicker, more refractory, very difficult to treat in my experience. And it may be because there's nothing to remove. We don't know the trigger. There may be something triggering, whereas at least you can pull away the statin, right? We talked about it, getting the disease getting worse, but nevertheless, at least you have the likely instigator to remove. For statin naive folks, for whatever reason, and also they're younger and they do worse. So for them, I think a pretty aggressive course as quickly as you can get to it. As you said, we started off giving methotrexate, azathioprine, mycophenolate, steroids. None of those, in rare cases, yes, you can get away with relatively minor immunosuppression. The vast majority of statin-naive patients seem to need rituximab. The vast majority of patients with statin-naive disease seem to need rituximab, and that's usually in combination with either methotrexate or mycophenolate. The steroid question is an interesting one. In 3 patients of ours, my colleagues published a small case series years ago in the New England Journal that reviewed exactly what you've said. But because of their diabetes, they either didn't want to or refused to go on a statin, or their physician felt it was on a steroid. Because of their diabetes, they were advised not to take steroids either by their physician, or they themselves were concerned about doing that. And statin associated myopathy HMG-CR myopathy seems to be able to be treated in the absence of steroids. I think that still goes back and forth, but I personally feel that the steroids were not helpful. And actually the patients themselves, which is an interesting little anecdote for those people who don't think about myositis a lot, steroids will almost always lower your CK. It just doesn't necessarily treat the patient. So these patients would come in referred from their outside physician, sometimes neurologists, rheumatologists, on steroids. And they said, my doctor says I'm getting better, because by numbers, their CK was dropping precipitously, sometimes even normalizing. And they would say, but I'm not getting better. And I think that's a wonder. I always teach my trainees that lowering the CK can be associated with clinical improvement, but steroids will lower your CK in the absence of that in many people. And I think this particular myopathy that's true of this. So I largely don't use a lot of steroids. The official guidelines do suggest that steroids should be started. I would say unofficially, I think more and more, hopefully one day we'll be able to have for hard data for that rather than just my observational sort of eminence-based medicine. I don't necessarily think that steroids are helpful.
I'm counting on you to help us have hard data, because again, when we reviewed the literature, it was a bunch of case reports and a bunch of anecdotes.
Right.
And trying to come to a conclusion about how to best treat these patients was kind of difficult, because there were a bunch of different cases people treated differently. My experience is low, 3 or 4 of these patients, but almost all of them ended up on Rituxan. So I just wanted to know, that may be right or wrong. That's what our rheumatology and neuromuscular people did. Can I take you back to those that are statin induced then?
Exactly.
What's your approach to those patients?
Right. So I do think rituximab, I agree with you. That's by far the most helpful therapy in those who are statin naive. I think IVIG to date is, I think, universally accepted as a very effective treatment for those who are statin exposed. And I often use it as monotherapy. As I just discussed earlier, we started seeing that clinically, and we've done that clinically since that observation that we could do that. We could use IVIG in the absence of steroids. Many of my, again, it is practice specific, but many people, and again, the sort of guidelines through the ENMC, which is European Neuromuscular Center guidelines, again, eminence-based guidelines, expert consensus, they suggest that a steroid plus methotrexate, then adding on your IVIG, and then if that's not helpful enough, then add on rituximab. So we do have several patients who are on both IVIG and rituximab. And in the opposite direction of the statin naive folks usually start on rituximab, but sometimes we add on IVIG for a boost, the other way around. And statin associated, we use IVIG, and then we sort of, if we really get stuck, IVIG plus another immunosuppressant like methotrexate or MMF, which mycophenolate. If we need something else, then it's rituximab. So some of these patients really do get hit hard with a lot of
that's
things.
very helpful to think about what the role of the IVIG is. I guess one other question I'll ask your expertise about is, who to refer to. And my experience, albeit small, has been it's really important who you refer these patients to. I have referred to an outside rheumatologist who the patient found could get an appointment fairly quickly. And it was, a very devoted rheumatologist. I had a chance to speak to her, and she was doing everything possible for the patient, but she clearly wasn't real familiar with the disorder. And then we have a neuromuscular group that the patient ended up with. But do you have any suggestions about should they go to neurology? Should they go to rheumatology? Should we all know somebody who's familiar with the disorder to refer these patients to? I mean, what would be your thought on that?
That's a great question. I think that community rheumatologists and neurologists could start on the therapeutic path we just discussed. I think that being knowledgeable about the disease is important. That patients who respond quickly, their CK normalizes, they get well. I think that those patients can be continued in a community practice or someone who has less experience. The red flags for me are patients that don't initially respond particularly well, are more refractory, might be progressive despite usual measures. Those patients probably require a little bit more clinical expertise for sure. The other thing that I think is a mistake made, I made it myself, is that most of these patients, I would hazard to say almost none of these patients can stop immunomodulation with IVIG or immunosuppression with something, either long-term therapy with rituximab every 6 months to a year or more. We can sometimes lengthen that interval. So we lengthen the interval of IVIG or rituximab. We can keep lengthening it. But in the patients I stopped the therapy, I sometimes had a hard time getting them back to their original baseline, even with restarting. So I have over time become very conservative in my approach of trying to stop immunotherapy. And that's not true in other myopathies. Many other subtypes of inflammatory muscle disease of myositis, we can actually stop the immunosuppression. It seems to be able to go into remission. It will fool you, and it looks fine. You stop the drug, and then it creeps its way back over weeks to months and sometimes a year. And some people respond again just like they did to begin with, but there is something of a signal where I can't always get the same disease control. So therein, I think lies importance in specialty care. The other reason, and not to make a plug for myositis centers, whether they're neuromuscular, many of these centers now that are, I think ours was one of the first models at Johns Hopkins, but I think that there are many models. The reason for someone to go to any center who has a rare disease is if something new comes up that is beyond IVIG and rituximab, or something that we're noticing that might be a risk factor that we hadn't noticed, for example, when you're in a clinical cohort, I think it's always best to be seen at least once to get an opinion of somebody who has expertise. The second reason is that, from a more, altruistic standpoint, maybe it'll help you, but maybe it will help others, is to participate in the clinical research studies, to answer a lot of these questions that you say you're counting on me to answer. You can only do that with data. The only reason we could actually see this in the beginning, where we saw it at all, was that we had enough patients where it wasn't one or two, it was starting to creep more and more. And so when you see that story 10 times, 20 times, 100 times, that's different than an N of one where you just won't see it. So for me, I always recommend that someone at least get an opinion once. But as far as long-term management, I think there's enough experience and or there's a partnership where they're seen in a specialty center, but the local rheumatologist or neuromuscular specialist and neurologist, who either of them who have some familiarity with disease or can learn, can do the day-to-day management.
Yeah, so I'm just going to make a comment to our audience as a lipidologist. Don't forget the anti-HMGCR antibody test, because I have found that occasionally you send these patients to someone who's not familiar with that. That's something you could do right away, is order that test on patients where you suspect this disorder. And as you already pointed out, it's highly specific. And if they have that antibody, now you can help with the diagnosis. I also love what you said about partnering with a rheumatologist, partnering with a neurologist. That's what I was able to do, is find somebody who was interested, familiar with the disorder, where we could partner on how to manage the patient, not only to treat the myopathy, but also to reduce the risk for cardiovascular disease when we had to remove a statin from the patient.
Exactly. I mean, that's the best care for the patient, and it's a great model in clinical care in general, for sure.
Well, I can't thank you enough for wonderful, in-depth discussion about a disorder that we think of as rare. I guarantee that everyone running a lipid clinic will eventually see one of these, mainly because for whatever reason our referring doctors tend to send them to us, and then we need to be able to recognize something much more severe than just statin-induced muscle pain that's self-limited. So thanks very much for spending the time and for wonderful discussion.
My pleasure. Thanks so much for your wonderful questions. I really do hope this helps patients in the future. Thanks so much.